Hi, good afternoon. My name's Wendy Randall. I'm one of the consultant midwives at the John Radcliffe Hospital. I'm here today, as I am every other week on a Monday, to discuss any concerns you might have about your pregnancy, labour or following the birth, and hopefully answer any questions you may have. So I will wait until you post some. Just now I will tell you about the things that are happening in maternity. Today I will only be able to be with you for half an hour. I'm afraid I'll have to leave you at 2 o'clock as I am teaching this afternoon. But in terms of maternity, we are still continuing with our plans as before. We have been very busy. So I think lockdown has contributed to a few extra babies, but we are all doing very well. The majority of our staff have been vaccinated. We aren't seeing the staffing shortages that we'd seen before, and at present we are planning the next steps. The government have a roadmap and we are trying to design our own roadmap in response to that, to work out how we're recovering for various aspects of the service. So the community midwives, the community team are working very hard at improving continuity of care, which has struggled a little bit over the pandemic, so that you ideally should only see a few midwives during your pregnancy and not a different face every time. We're looking at our plans to resume normal community care, because we again had to make some adaptations and there's been some telephone calls, so we're working with GP surgeries to see if we can get back into GP surgeries to go forward from there, and really about reintroducing bits of the pathway that we've had to take out over the pandemic to try to make sure that we were still providing care. So we're doing everything that we can, and as soon as we have worked out any changes, we promise we will share them with you in many different forums, but obviously this would be one of them. So I can see some questions have come in, so the aim of this session is any questions posed, I will read them out and try and answer them. If I can't answer them, I will get the information and pass it back to you. So Catherine has posted, the consultant confirmed at 36 weeks that you would have a caesarean section at 39 weeks. When and how will I be booked in and get an exact date? So when you see someone in clinic and they agree that a caesarean section is that they can get it booked, they provide the information to the antenatal team, who are then looking at they look at the availability and the planning of it, and they arrange your preoperative appointment and the date of your caesarean section, and they will be in touch with the details. Catherine, it is a provisional date, and it can move at quite short notice in the week even running up to the caesarean section, because we can only do so many planned things a week, so we have to sometimes move women about to enable us to provide the right care at the right time for other people. So please be aware of the provisional date when they give that to you. And I know that there has been some juggling about in the last, certainly in the last month, with women to try and make sure that the caesareans are at the right time and right date for people. So somebody will be in touch, and if not, if you haven't heard anything within a week, Catherine, then you could contact your community midwife and ask for details from there. So Ella Rose, so you said, hello, so with the new roadmap, I'm due May the 28th, how many birth partners will you be allowed? So Ella Rose, at present we haven't got firm dates on our new roadmap, which, like I said, as soon as we've got them, we will share them. But we are going to try one of our initial factors, which is still in the planning stage, is to start with things like enabling partners to be present for scans, etc. So in terms of birth partners, it might be one of our later things to prioritise in our roadmap. So I'm not sure, because the 28th of May is obviously still a good couple of months away, but I promise you it's one of our things that we are looking at in terms of the steps. So at present there are no changes, but as soon as we've got that roadmap mapped out, we'll get that to you so that you'll all know. Rebecca, you're saying, are water births possible currently with COVID? Because you had a mixed message at an NCT class recently. So Rebecca, for everyone, we've continued to provide water births throughout COVID. It's not been something that we've stopped unless a woman is unwell with COVID symptoms. So if a woman is unwell with COVID symptoms, then being in the bath is not the best option for her. So, and those, I don't think we've had any women in that scenario who wanted to use the pool who couldn't. So in answer to your question, yes, water births have continued. And on that line, Rebecca, normally I would have a yearly update with the various education providers, which would have been in October. But obviously because of the pandemic that didn't happen, so I'm sorry that we haven't kept the NCT up to date with that, and we'll try and rectify that moving forward. Naomi, you're asking, are you trying to put ladies in their own room after birth due to COVID, or will we be sent to the ward bays as usual? So Naomi, the women who are testing COVID positive are put in a specific ward area in single rooms to keep them isolated, because we have to do we have to wear an additional level of protective equipment and do what we call barrier nursing. But so because we're testing you while you're in labour, we know that we're putting you, if we are putting you into bays, it's because those are women that aren't testing COVID positive. So yes, it would just be if you have to stay overnight and you birth on delivery suite. If everything's well, you may get the option of going to the postnatal ward on level 7, but otherwise the postnatal ward on level 5, which the rooms on level 7 are single rooms, but on level 5 it's predominantly 4-bedded bays. So I hope that answers that question. Emily, you said, is there any roadmap to do with visitors after birth? I mean, more specifically, the partners being able to come in with existing children. So Emily, again, this is something that we are looking for in terms of the plan, in terms of resuming contact with partners being able to come into the postnatal ward, which we feel is really important, because partners have voiced that they're missing that key time after the birth of their babies. So that is something that we're looking at. I'm not sure in terms of existing children. I think we would prioritise partners being able to come back to visit first before introducing extra numbers like children. And I appreciate that children are at a lesser risk in terms of spread of COVID, but it is obviously something that we're trying to map in. But yeah, the pathways that we're looking at are, we're trying to get back to where we were before, and we're going to stage it depending obviously what's happening with the infection rates. Because I'm sure, as you realise, whilst we're all delighted that our children could go back to school today, you know, they're also sitting looking at levels to make sure that just by doing that doesn't increase our levels too far to mean that we have to then stop going any further. So fingers crossed we're on the path back to recovery. So Joanna, you're saying your baby's due on the 4th of May. Is there likely to be any ease in restrictions over the coming weeks in terms of being allowed to have a second birth partner? So Joanna, like I've said a few minutes ago, I think that the second birth partner is probably a little bit further off. Our main focus is on partners' presence at scan, where we were before. So we want to get back to where we were before the lockdown, when we enabled partners to attend the scans. And then we want to obviously get back to partners being able to come and visit postnatally. So I think birth partners will be a bit further along the line, because we haven't made any change to that since we went into the first lockdown. So I suspect, though I may be wrong, that won't be the case at the beginning of May. So I am sorry about that, but again, we have to do much like the government are doing, little bits at a time, because we don't want to go backwards again. So Tara, you're saying you're due in 3 weeks, your baby's measuring small throughout until your 36-week scan, which showed she's measuring fine but small. There was a mention of not going past 40 weeks by the doctor before, but now she's measuring okay. Will there be a chance of me doing this naturally without being induced? So yeah, I mean, Tara, that sounds very positive. You know, we have babies that are constitutionally smaller. So when a baby is first small, we do recurrent scans to make sure that they're constitutionally smaller, and not because there's a problem with the growth of the baby. So it sounds like they've done that monitoring and decided that your baby is actually normally grown for you. And so we would encourage you to go into labour naturally. And then induction, of course, would be offered to you from around 41 plus 3 to 42 weeks of pregnancy, but with the hope that you'll go into labour beforehand. So that's very positive, Tara. I'm sure that's a weight off your mind after being worried that your baby's too small. So Lauren, you've asked, can you have a water birth with pregnancy-induced hypertension? So Lauren, the key thing is how your blood pressure is managed in labour. If your blood pressure is getting very high and we're having to use different medications, then being in the pool probably isn't the best option for you. But if your blood pressure is higher than it normally is, but is not spiking, then using the birthing pool can be very relaxing and maybe actually helpful for you. So we do have a pool on delivery suite, and we do have wireless monitoring to enable you to use the pool, because one of the important things is making sure baby's okay in labour, and that's the continuous monitoring of baby's heart rate. But like I said, we can use that in the pool, so you know, do include that in your birth plan, so that midwives looking after you can help support that as one of your choices. So Emma, you said, if your baby is still breech at the 36-week growth scan, what is the process for breech clinic, and can my husband attend if I choose an ECV? So Emma, for breech clinic, we have continued to support partners to attend the breech clinic, because there's a lot of information to process, and we feel it's quite important. So if your baby is breech and you go to the breech clinic, then your partner, yes, would go with you. Nikki, you're 32 weeks and your baby is breech. At what point do discussions start happening to manually move baby if possible, or alternative birthing options? So Nikki, what happens is it's at the 36-week scan. If your baby is felt to be breech, you will be referred to our breech clinic, where we will talk to you. We will scan baby to see what position it's in and counsel you as to whether it's appropriate or not to turn the baby. Because obviously it depends whether baby's tucked up in a flex position. Sometimes they point their chin up into the air. So we need to look at how baby's lying, and you know, and if we feel baby's in a good position, we'd encourage baby to turn, and then obviously depending on what happens, they will advise you round about in terms of next steps. So Camilla, your midwife noted that you previously had an MRSA infection and has agreed to re-swab. If this comes back positive, I assume I need to undertake Hibby scrub, etc., and have a negative swab before going into labour. Yes, so we'll go through our standard MRSA infection protocol with you. Yes, so we'll arrange the re-swab, and then there is Hibby scrub treatment, etc. You know, it's been a long time. We don't get very many people with that now, so I would actually have to double check the guideline, but I'm sure your midwife has looked at it. But certainly previously that was what we did. Hopefully take that on board. Charlotte, you're 39 plus 2 and last Monday your blood came out. You've had a few twinges since, but nothing consistent. Any ideas how I can get things going as I'm so uncomfy? Charlotte, you know, I wish we could solve this problem. You know, it's one of these things. We know that there are different things that we can do to encourage labour and birth, but is there a robust body of evidence that says that one works over the other? Not necessarily. I mean, even from a stretch and sweep perspective, if you do a stretch and sweep on 10 women, 3 women will go into labour within 48 hours. 3 women will have some changes to their cervix but won't labour, and 4 women it will do nothing for. And the thing about the evidence base is you can't prove that those results were anything to do with the stretch and sweep or whether they would have happened anyway. But we do know that a stretch and sweep stimulates natural prostaglandin. There is natural prostaglandins in semen, so that's why in the past intercourse has been encouraged. We talk to women about hand expressing, because hand expressing stimulates oxytocin, and oxytocin is one of the hormones that helps you to contract. But I think the biggest bit of advice is to try and relax and not get too focused on it, because that it causes anxiety, and anxiety actually suppresses your body's natural oxytocin. So balance exercise with rest. You don't want to be climbing hills the whole time and ending up exhausted. You know, you can look up hand expressing, or they call it colostrum harvesting, on the internet. You can talk to your community midwife about it to get the oxytocin going there. But generally it's a balance of feeling nice and relaxed, and baby will come when it's ready. I mean, the fact that your plug, your shows come out is good. It sounds like there's a bit of change happening to your cervix, and it will just all happen. But try not to get too focused on it, because when we get too focused on it, we do get a bit more anxious, and that isn't helpful. So I'm sorry I don't have the golden rule, and some people talk about pineapple. Don't know if there's any evidence behind pineapple. You know, other people talk about castor oil. Please don't do that. All it does is really upset your stomach, and isn't terribly helpful. And I think curry is much the same thing. It just gives you a good clear out. But yeah, again, I think my key thing is just try to relax. Some people believe in acupuncture or reflexology, but unless you have a friend that can do that, which, you know, I suppose socially distancing if they're on your feet, but yeah, it's a bit more difficult to get hold of practitioners in the lockdown. Thank you, Rebecca, for your lovely feedback. So Helen, you've said what constitutes a small baby, please. You know people who've had larger firsts than your daughter, and they are receiving additional growth scans for having had a small baby. Okay, so growth scans are all done on measurement in terms of centiles. So basically, the 10th centile is the lower centile for measuring a baby's size, and you will see you had a scan diagram that has various lines. So the bottom line is the 10th centile, and a constitutionally small baby is one that either sits on that line or just underneath that line, but they're following the same curve. So at each scan measurement, they're still at exactly the same point on the graph, which shows us that for that person, that baby is small, but it's growing at the same rate the whole time, so it's not a concern. If you have a baby with growth restriction, what tends to happen is they start off, say, on the 50th centile, and as the weeks go on, the measurements go such that the baby drops under that centile and can end up on the 10th centile because their growth has plateaued. So it hasn't continued to increase as we would expect it to follow on the natural curve, which goes up. In terms of large babies, some people have constitutionally large babies as well, who sit on the 95th centile, which is that top line. And so they might always sit on that line or just slightly above that line. But again, the growth has been consistent the whole way through, and it's always plotted on the same line. And that's what roughly you'd expect for somebody. If your baby was plotted on the 50th centile, which is the middle one, we'd expect it to follow that 50th centile throughout. When it suddenly goes up above a few centiles or goes down below a few centiles, that's when we get a bit worried that perhaps growth isn't as we would expect it to be. I'm not sure. I'm not sure in comparison to your friends or what that means, but that's how we process things in Oxford, and should generally happen in most maternity units. But I'm not sure. The only thing I could perhaps think about is that they had a baby before who was on a larger centile and has dropped off its centile chart, so thus it's indicating that there might be a degree of growth retardation rather than the constitutionally large or constitutionally small baby. Emily, you're saying, if you and your baby are well but overdue, are you able to decline an induction, and for how long past your due date, as long as you're both able, as you're both well? So, Emily, induction of labour is absolutely a choice. We're aiming in Oxford from the beginning of April to offer women slightly earlier inductions if they want, because and from that I mean probably from 41 plus 3 onwards. That's something that we're working towards, and the aim of that is because people want more choice. They want to know that they could have their baby a bit earlier because they have anxieties, and some people of course want to go later, and that's absolutely fine. For us, our key thing is to give you the information that you need to make the best choice for you. Our main concern about length of pregnancy, especially if it goes past 42 weeks, is that there is an increased risk of stillbirth. Now, that risk is absolutely very small, but after 42 weeks, it does double. So it's still very, very small, but anytime there's double a risk, etc., we start to just get a little bit more concerned and offer women the choice to be induced. And our problem with the delay factor is we don't actually know, we don't have a diagnostic test that says that this pregnancy is going to be okay, but this pregnancy isn't. And we can offer monitoring every day of the baby to try to provide some reassurance, but the only reassurance it really gives us, Emily, is that the baby is okay at the time we've done the monitoring. So it doesn't tell us that the baby is going to be okay for 1 hour, 10 hours, 24 hours, 48 hours. It just tells us at that time that we do the monitoring that baby is okay. So we have had babies, and we have had experiences of women who wanted to delay it, and everything's gone well and they've gone into labour. And we've had instances of people who've chosen to delay it and things haven't gone so well, and we've had to have to deliver their baby quite quickly. And so for us, it's very much, there is a balance. Some people feel their dates are wrong. Some people feel very well and are having some twinges and would rather delay it. But the really important thing is induction of labour is a choice. And I think you need to have that conversation with somebody so that you feel that you've got as much information that you need to make that choice. So I'm sorry that's a bit vague, but I think that hopefully the thing that I've been able to convey to you is that induction of labour is a choice, and that there is time if you want to have time, and we will support you with whatever you want to do. But we'll probably just, rather than just your community midwife, we'd arrange for you to talk to either myself or one of the other consultant midwives, or an obstetrician, just to make sure that we've answered all your questions and helped you with a plan. Because some people feel they might 1 or 2 days, some people felt they want 1 or 2 weeks, and we want to know if there's any monitoring you want, etc., and any support from us. So hopefully, Emily, that answered your question. Oh, thank you very much for positivity, OMVP. Now, I have got just 5 more minutes left, I'm afraid, so I'm going to look at the next few questions, purely because, like I said at the beginning, I am going to have to go and teach. So I'm going to cover Jackie's question, hopefully, and Camilla's, and then I'm going to stop, if that's all right. If you have any burning questions, if you message Maternity Voices Partnership, they can get in contact with me and I will answer them, or you can contact your community midwives and ask them. But I'm just going to do Jackie and Camilla's questions, and then I'm really sorry, but I have to stop today. And I wouldn't normally cut it short, but just juggling a few other things today. So Jackie, you've asked, are sterile water injections now being used at the GR? Is it possible to have it for home birth? Absolutely, Jackie. We are so excited. And I don't know if you can see in the background, but I have a poster here about our trial that we did, and it was incredibly positive, because what we showed is that they really make a difference to women that experience constant back pain in labour. And the beauty of it is it's only water, so we can use it anywhere. And we've been on a mass recruitment, or not recruitment, but training exercise, training all the community midwives and midwives to do it. So if you're a community midwife who's at your home birth isn't trained to do it, we can find somebody else, hopefully, that is trained to do it. But we're trying to ensure that everybody has that skill to do, because it makes such a difference to women who have that constant back pain in labour. So I hope that reassures you that it is happening. Camilla, you said someone at your antenatal group had contacted the GR after being recommended by the midwife due to possible reduced fetal movements. However, she was told to see how it was in the morning. What's the typical procedure for concerns about reduced movements in the third trimester? So Camilla, the advice to women who phone up about reduced movement, so we encourage women to look at their normal pattern for them during pregnancy, and hopefully you've had the Tommy's leaflet from your community midwife about reduced fetal movements, and if you haven't, if there's anybody out there that hasn't, you can easily get it online or ask your community midwife. And Tommy's is capital TOMMY''S. It's Guy's and Thomas's charity that provide lots of information and resources which are really helpful. If you feel that your baby's not moving as much, you should phone the maternity assessment unit. Out of our, well, they're 24 hours a day, 7 days a week. Monday to Friday, there's the day assessment unit at the Horton, which is also called Midwifery Assessment Centre, or MAC, which I think has midwife there sort of 8:30 till 4, Monday to Friday. But basically, if you have concerns about movements, you phone up and we'll ask you some questions. We do tend to encourage people to go and spend some quiet time and lie down and pay attention to their movements, because we find that if you're busy, especially if you have a toddler or you're working still, you can get so involved in what you're doing that perhaps you're not as aware of how often the baby is moving. So we do tend to say to people, if you can go and lie down, sit down and think about your movements, and when you sit down and think about them, you think actually they are there and that's probably about normal, then that's reassuring, and you wouldn't need to come up and see us. But if you sit down over that sort of hour or two and think, actually, do you know what, I still can't feel them, and this is when I would normally feel baby move, then please do contact the centre again, because we should really see you. So I wouldn't like to think that somebody was turned down from going in if they phoned back and said, actually, I have concerns about movements, because part of it is escalating to us so that we can check everything over and make sure that you and the baby are okay. So I hope that answered your question. So again, I'm sorry I've managed to cut this a little bit short today. It's lovely, and feel very honoured to have this time to be able to talk to you and hopefully reassure you that we're still providing as full a service as we can at the minute, and of course we will be working towards getting back to normal. We've got a meeting this week again looking at next stages, and I am in touch weekly at minimum with the Maternity Voices partnership team, so that if they have any concerns or anything that they want to challenge us on and make sure that we make better for you, absolutely, that's what we're doing. So I'm really sorry again to cut today short, and if there is the need, then obviously I can perhaps come back next Monday, but for today I'm going to say goodbye, and just remember to keep following social distancing, keep yourself safe, and please, please, please remember that if you have any symptoms that you think are of COVID, please, or you're diagnosed as positive with COVID, please let your community midwife know, because there's some extra things that we have to do to try and keep you and your baby as safe as possible. So thank you very much for today. Take care, everyone.